Hello and welcome to Yodo. I'm Dr. Bohn.
And I'm Dr. Tartaglia.
And today we're going to talk about continuous care. Continuous care is a level of care that is provided by hospice in your own home. So you've got a patient, their life expectancy is limited 6 months or less, and they want to be at home. Continuous care, home care, is for when the individual is having a symptom that's not well managed and a nurse needs to be there bedside for several hours to help manage that. So the nurse will come to your home and will stay in the home.
And usually it's done on a 12-hour shift basis. Most hospices I worked for, sometimes it is 8-hour shifts, and that's usually when they will have a CNA, a certified nurse assistant, instead of a nurse if they have staffing issues. So at least 18 hours of it has to be provided by a nurse by Medicare guidelines, and most often it's 24/7. But we're told as hospice physicians never to promise, don't overpromise because we don't want to underdeliver. But like Dr. Bohn was saying, these patients are already on hospice services or could be admitted directly on continuous level of care, and they have symptoms such as nausea, vomiting, pain, agitation. Something significant has happened. Maybe their underlying disease is in an exacerbation.
So it's not that they come to the house based on the disease. They come because the disease is not well managed, and it's not just something like a simple pill change.
Right.
But they actively need to be monitored as medications are changed or administered. So most commonly, I would say it's pain, nausea, shortness of breath, and the patient may already have meds, may already have oxygen, but for whatever reason, the nurse needs to be there so that she can monitor the response and contact the physician on an ongoing basis with the response report so the physician knows what to do next.
Yeah, and oftentimes families will get very concerned when there is a change in care, change in the patient. So for example, when a patient is normally up talking and they become unresponsive or they're less conscious and they're sleeping more, that does not warrant a continuous care. But we will get a lot of calls for that, and of course usually the hospice physician, the team always goes out when there's a change in care. But if they're comfortable and that's that their disease prognosis is 6 months or less, this could be part of the stages of passing.
If the disease is just progressing as anticipated, then they may not feel like continuous care is warranted. But at any time, remember, you can call your hospice agency and say, hey, there's a change and I need the nurse to come. And it might be, 2 o'clock in the morning, the night of a holiday. And if you're uncomfortable, if something's happened, whether they're in pain or they're just unarousable, you need to call them and tell them, I need the nurse to come and look at this. The nurse is the trained individual, not you.
Yeah, and that being said, just bear in mind that this is a hospice that you're calling. You're not calling 911. So it will take time depending on what the needs are of
in the
patient
area
and where the nurse is in the area. If your territory is a large, massive county, which Dr. Bohn worked in the largest county in Florida, and I worked in a very vast area, it will take time for them to come out. But it's just nice for them to come out at 24/7. They will come out. They also have authority to call the on-call physician, or if it's a nurse practitioner that's on call, to receive orders to have medications changed. And generally speaking, there is always a 24-hour pharmacy to get medication.
So let's give a scenario, and then maybe that'll help with the understanding. You're at home with your loved one, and they get up to go to the bathroom in the middle of the night, and maybe they fall. Or maybe they get up to go to the bathroom because they're sick at their stomach. And on the way to the bathroom, maybe they become short of breath. But now there's this acute change that has occurred. You get them back into bed. They're still having symptoms, and you give the medication, or maybe you can't remember what medication to give, so you call the nurse. And you talk to the nurse on call, and she'll tell you, walk you through it. You give her the history of what's recently happened, and she'll ask what you have, what you've already given, and then she'll advise you over the phone. But if you tell her, I'm not comfortable, I need the nurse to come, then they're going to send the nurse out to do the assessment. If the nurse goes out to do the assessment and the nurse finds that these meds have been given appropriately and the patient is not being well managed, she has the authority to call her supervisor and tell him this patient needs to be monitored continuously.
Yeah, and then they call a physician on call to get the order to start the continuous level of care. And basically what that means is that primary nurse of the patient will visit daily. If that person is on vacation or unavailable, there will be a nurse to visit the patient daily. It also invokes the rest of the interdisciplinary team. Usually the social worker and the chaplain, they're only really required by Medicare to make monthly visits, but they now will come, and they will come as frequently as families need. Some of them have to go daily because symptoms are very exacerbated, so family is in distress, and sometimes it might just be once a week. By Medicare guidelines, there needs to be a physician seeing the patient at minimum of 72 hours. I was an overzealous medical director. I was kind of a mean physician. I expected my physicians to evaluate the patient every 24 hours, only because we need to be making changes, right? How are we going to get the symptoms managed if we're not there visiting the patient?
And it's a lot of responsibility on the nurse. Now, with the video visits being approved, physicians can get some information by the video visit, but it's not the same thing as being there and communicating with that patient and with that family.
It's really true. And that's one of the blessings of COVID is the acceptance of video visits. Before COVID, we never did that before, but now you can have video visits and you could be anywhere, which is good because a lot of times the workload is vast for the physicians to go there. That being said, we have the continuous care and we are always evaluating it to see if the patient stays on that certain level of care. And what I mean by that is the team meets, we meet weekly, but they're always in discussion. So if a patient's not really, medications aren't needing to be changed and their symptoms become well managed, then we begin the discharge planning process.
And so then you go back to, you're still at your home, but you go back to that prior level of care, that routine in-home care, where the nurse is coming by a few times a week. Now, if you just came off of continuous care, she's probably going to be coming pretty often to make sure that stability and those continues and those symptoms continue to be managed.
Yeah, our goal as hospice providers, when I was a hospice provider in my former life, is to keep patients out of the hospital. We want patients to stay on hospice so they can receive the hospice Medicare benefit for as long as they can and live as long as they can symptom-free. And what we don't like to see is the back and forth to the hospital. It's so disruptive for the patient, for the family. It creates a decline in the patient. Stress.
And that's what most patients and families tell me. I don't want to go back because every time I go back to the hospital, by the time I get home, I'm not as good as I was when I left. I get worse when I'm in the hospital. And we have a whole video on how the hospital is not as safe as what you think. And that's one of the things we discuss in that hospital is how people can decline and actually get worse while they're there. They don't get better. Diagnoses get made there, surgeries happen there, treatments occur there, but the patient typically gets worse while they're in the hospital because of decline that occurs from inactivity and being so sick that they're in the hospital.
Yeah, and I want to circle back with a patient that I recently took care of. I have my own business, so I do palliative house calls and I do telemedicine platform. And this patient was referred to me because he had a very significant illness that he had prolonged hospitalization of 45 days of a new diagnosis. And he was in a rehab center. After he came out of the hospital, they put him to rehab, and he was failing to progress because he had a progressive illness. So the family reached out to me because they were just trying to understand, what are we talking? Days, weeks, months? And I helped guide them. And then we found a place for him to move to because moving home was not safe. And then I discussed with them, I think it's time, we bring hospice in. And this is where the story gets interesting. I arrive at the facility and I'm seeing the patient. I wanted to be there when they arrived because it was my recommendation. And I'm talking with the patient who would speak very softly and have to write down he had a progressive neurological illness. And the wife comes to me because, the hospice was there to sign all the paperwork, and she had my DNR, and she says, Dr. T, I looked at his living will, And you're right, his living will says he doesn't want machines, and he was on a feeding tube. So he was being admitted on a continuous level of care at this new place because it was our first time managing the feeding tube, and he was at a high risk of aspiration, meaning the feeding not going into his digestive organs, but rather his lungs, and he was very congested. So the continuous care staff was there, everybody was there, right? And she said, well, I need to speak to him because he was of sound mind. So in my 20 years, never in my life did I see such a strong, selfless man who was the patient and was in the early stages of, decline. And his wife said, she's a retired teacher. I want to read this to you, and we have a tough choice. And at that moment, he said, no, it's not a tough choice. He wrote down, not a tough choice, no more feeding.
Wow.
So this was beautiful that I had the hospice there. They had the continuous care. So the hospice was like, whoa, because that takes a huge burden for them to have the conversation, because I had the rapport. But what was so overwhelming is he opted for no more feeding. We honored his wish, and thank goodness he had the continuous level of care, because he did have symptoms to manage, which were pulmonary congestion. His lungs were very filled with fluid. He passed in the next couple of days very peacefully, but it was nice for the support because he was having a change in his level of care, meaning he moved from a rehab to his new home, which was an assisted living, and he opted for no more feeding.
To kind of tag on to what she's talking about, no more feeding, many patients and families especially fear that no more feeding means the patient's going to starve to death. Death from no feeding takes many, many days, sometimes several weeks. And to pass away within a few days, this individual was not dying because he decided he didn't want his feeding tube. The feeding tube might have been what was causing him that pulmonary congestion. And it actually might have accelerated his end of life had he chosen to continue with those feeds, because it sounds like the feeding was actually putting more congestion into his chest and lungs.
Yes, and he was an elderly gentleman who also had congestive heart failure. So what I said to him when I first met him, he already is starting this game of trying to fight to live with half of a deck of cards, because he was very, very compromised cardiac-wise, and then he had a progressive neurological illness that did not allow him to take food in by mouth. So it was a very ebb and flow, very difficult to manage patient.
The other thing that Dr. T brought up earlier was about the interdisciplinary team. It is not just the patient that's suffering, that has symptoms that need to be managed. It's also the family and the friends. And that's why social work may need to come by, and they'll take part in that continuous care. They may come and spend a few hours in the home talking with the patient, talking with the family, or if there are close friends, they'll talk with them. And the chaplain is there, and they provide that spiritual guidance. They do know religion, but they're not to take the place of your religion or your religious leader. They have spiritual training and can help guide that family through the spiritual concerns that they have. But every one of the team members has a part that they do for that patient and for the family.
Yeah, and the good thing about having continuous level of care is you are giving the care within the home. So the interdisciplinary team can also look at the home setup and make sure that it's a safe environment. A lot of times people, the reason why they don't want to leave their home is because they do have their little safe environment. They have their their walker with their purse inside the walker seat. Their snacks are there, their medicines are there. They then get up and they can go to the bathroom. They know the distance and the trajectory to the bathroom. It's where they're comfortable. So it's also really important when you're looking at the continuous level of care to have the whole team help to make the setup more comfortable. Because sometimes the environment for the patient needs to get smaller and smaller, meaning they can no longer go to the bathroom. So now let's order a commode and let's have that next to wherever they're sleeping, so that they still have dignity and some control.
I want to point out, we keep talking about home, and that doesn't necessarily mean a private home. A lot of people think, well, they can't stay at my home, or they can't be at home anymore. We're talking about the patient's home environment, which could be a private home, their private home, a family member's private home, a close friend's private home, a nursing home, an assisted living. An independent living facility may actually be the patient's home environment that could support that patient during continuous care. What happens after that would depend on, and where that home environment is, would depend on how the patient does during that continuous care. We've taken care of people that live in a tent. So it really kind of depends on what that patient's home-like environment is, where the home is.
Right. And just for those patients that we're taking care of in a tent, now that patient, if they're having acute symptoms, we have to look at, is there electricity?
Is it safe for the nursing staff?
Yeah, so then that would be a patient that we would move to an acute inpatient level of care. So there's just a lot of moving parts for the hospice Medicare benefit, a lot of idiosyncrasies with different levels of care, and we just want to give you the information. And then I also want to give a caveat because I myself grew up in the Northeast, and the levels of care are not the same there. When my loved ones were dying, there wasn't the robust hospice team. Now, again, let me give another caveat. This was in the early 2000s, so in maybe 15 years, things have changed. But we are very lucky in Florida because we have a really robust hospice. And because we're robust and because there's competition, it keeps us current.
Yeah. And having more than one hospice, some of our counties actually have 5 different agencies. Not so many that they don't provide good care or there's too many choices for patients, but we have enough to provide that competition that they really compete with each other to try to provide excellent care. And like Dr. T, coming from the Midwest, we didn't have that robust inpatient care unit either. We had good levels of care for respite. We had good levels of care for continuous care in the private home like we're talking about today. And we had really good routine in-home care. But we didn't have an inpatient care unit where I practiced in mid-Missouri.
Yeah. So I just wanted to give you that caveat and let us know if you have any questions, because we know what is required from the hospice Medicare benefit. We also have the proper verbiage, and we can help our viewers.
Some of you may know if you have inpatient units, if you have ability for continuous care in your area. We've run into some recent issues because of staffing problems where hospices want to provide that continuous care, and they're really encouraging patients to come into their inpatient care unit and leave their private home because they just don't have the nursing staff to provide that continuous level of care. So that covers a lot of information about continuous care, and if we've left something out or if we've prompted a question, please let us know in a comment below.
Yes, and we are here to help you. We know navigating hospice is tough.
Scary.
It's very scary. It's the H word that nobody wants to talk about. But
Dirty H word, hospice.
Yes, the dirty H word. But we just hope that with our videos and the knowledge that you, our viewers, are going to gain, it will just give you some peace of mind. And we thank you so much for watching our video.
I appreciate you.
Bye now.
Bye.